Welcome to the Chiro Up 15 Minutes to Excellence webinar, where our goal is to provide you with useful new skills in 15 minutes or less. I think you'll enjoy this webinar, Spinal Instability. It's part 6 of our Explosive Outcomes series, named because clinicians who can identify and correct these 7 underlying functional diagnoses will typically obtain much better outcomes. Traditional structural diagnoses focus on a tissue for the patient's symptoms, much like a lumbar disc or a lateral epicondyle, whereas spinal instability is a functional diagnosis that requires identification of the underlying factors that contributed to those structural lesions. The diagnosis, when missed, delays recovery and it frustrates patients, providers, and payers. And I think one of the most overlooked functional diagnoses is spinal instability. Functional spinal stability is required for the spine to bear loads and to move and perform optimally. That helps patients avoid injury and pain, and it requires 2 basic components. Number 1, the strength of the supporting musculature, and number 2, dynamic coordination of those muscles through the central nervous system. If you've ever played the game 4 Picks in 1 Word, you know how that goes, and what we're looking for is what do these 4 pictures have in common. And the word we're looking for is guy wire, which really is the stability of each of these. That the structure, whether it be a bridge or a ship or a telephone pole or a parachute, requires these wires for stability. And if those wires are not functioning properly, there are problems. So in the spine, that too requires guy wires for stability, and those are the muscles. And those muscles allow for a process called centration. That means a joint maintains a neutral or centrated position throughout its range of motion. That reduces the strain and stress on ligaments and capsules and cartilage and joint surfaces, and it allows the muscles to perform optimally. When there's weakness or imbalance in one of those muscles or guy wires, that decentrates the joint and places the tissues around it at greater risk. So what happens to uncentrated joints is what we treat as chiropractors on a daily basis: strains and sprains, joint dysfunction, and osteoarthritis. Over time, these deficiencies or injuries and weaknesses in spinal stabilizers require compensatory recruitment of other muscles, and that changes our movement patterns. This can lead to strains and overuse injury, and over time, learned dysfunction. We see 2 pictures here with very different learned patterns of function, and that very well may have started from muscular imbalances or deficiencies and changes in training over time. So what is core stability? Well, core stability is dependent first upon the abdominal canister. The front and sides of the canister are formed by the transverse abdominis muscle and the intercostals. The muscles of the pelvic floor form the foundation of the canister. The diaphragm forms the roof, and the paraspinal muscles, including the superficial lumbar erectors and the deeper multifidus, form the back of that canister. And the muscles need to be activated in a complex synergy, that they need to fire in a certain pattern. The diaphragm initiates that pattern. The muscles of the pelvic floor follow very shortly thereafter, and then the eccentric contraction of the transverse abdominis and lumbar erector muscles is required in order to pressurize that canister. So if the canister has a leak in it, here's what that looks like. Here's a video. The can on the left is closed and it's stable. And so when pressure is applied to that can, it maintains its stability, whereas the can on the right is open, and an external force creates instability and obviously damage. Another way to think about this is much like a ship, that if you were going to fire a cannon, would you rather fire that cannon from a very stable foundation like a battleship, or a relatively unstable foundation like a rowboat? Well, when you're firing consistently from the rowboat, you're going to develop symptoms. And those symptoms mean that there's an acute or repetitive stress that's resulted in a displacement beyond physiologic limits. So this is stressing those tissues out of their centrated position, and that's going to lead to low back pain, chronic groin pain. We also know that it can lead to distant injuries like knee problems and shoulder problems. So how do we identify spinal instability? Well, first of all, we're going to look at breathing evaluation, because we know the diaphragm is the roof of that canister. We're also going to assess the tests within the spinal instability cluster, and those tests are assessment for aberrant motion during lumbar flexion, the active straight leg raise, prone instability, PA shear, passive lumbar spine extension, bridging maneuvers, and obviously assessment of breathing. So let's go through those quickly. The assessment for aberrant motion begins by having the patient stand and flex forward. What we're looking for is pain while the patient bends forward or returns, Maybe there's a catching or a sudden acceleration or deceleration of trunk movement, an unexpected lateral flexion or rotation of the trunk, or maybe the patient needs to use their arms to return to an upright position. If the patient performs knee flexion or shifts their pelvis forward, those are other signs of aberrant motion, and the presence of any one single aberrant motion suggests spinal instability. Another simple assessment is the active straight leg raise, and this is simply asking the patient to actively lift their straightened leg as high as possible. You're going to compare this from side to side. An elevation beyond 90 degrees suggests instability with a relatively high level of inter-examiner reliability. Another test, now this is not specific to instability, but it's a component of the next test, it's PA shear, and this is simply having the patient lie prone while you apply about 2 pounds of force through each of the spinous processes in a posterior to anterior direction. Each joint should be assessed individually, and you're looking for joint play and end feel. And limited end feel, or reproduction of patient symptoms, is a positive test, and it suggests joint dysfunction at that level. But that dysfunction could either be restriction or instability. So the way that we differentiate those is by adding artificial stability, and that's the prone instability test. So the only difference between this test is now we have the patient lift their legs off the floor. That causes an activation of the deeper lumbar and superficial lumbar musculature, and then we reapply that same 2 pounds of force through the irritated spinous process, and we determine, is it as painful? Symptoms that disappear when this test is performed when the patient is lifting their legs suggest that spinal instability is the source of that dysfunction rather than restriction. And again, this has a relatively high level of inter-examiner reliability. Another test is the passive lumbar spine extension test. This has relatively high sensitivity and specificity for spinal instability. We perform this test with the patient lying prone, their knees are locked in an extended position, and then you gently traction the patient's leg and simultaneously elevate both legs about a foot off the table. An increase in lower back pain or discomfort or a sensation of heaviness means that the patient likely has some degree of spinal instability. The last maneuvers are the bridging maneuvers. This can be performed prone by having the patient prop up onto their elbows and lift into a straight bridge position, or having the patient perform this supine, and in this case the patient's knees are flexed, their feet are on the table, and lifting their pelvis again into a straightened position. And what we're looking for is can the patient maintain this without shaking, without moving, and what's the endurance? And this can give us a insight into how stable their musculature is. Now, to evaluate the roof of the abdominal canister, we're going to look at diaphragmatic function, because the diaphragm has two functions. Not only is it necessary for respiration, but it's also a postural stabilizer. So the way that we assess breathing is we're going to observe the patient take a breath. We're going to watch, is there elevation of the upper rib cage, or inadequate or asymmetrical lateral rib cage expansion, or does the patient initiate breathing from the abdomen or the chest? One common dysfunctional pattern is called paradoxical breathing, and this means that the patient is initiating breathing by elevating the shoulders and the chest rather than by expanding the abdomen. For an assessment, we can have the patient lie on their back, place one hand over their chest and the other hand over their umbilicus, and we're looking for initiation of a deep breath which occurs at the abdomen. So here's a video of that happening. The patient is applying pressure in each area. We instruct them to take a deep breath, and we're looking for just the hand over the abdomen to move. The hand over the upper chest should remain relatively still. We can continue this assessment then by standing behind the patient and placing our hands on the patient's rib cage while the patient takes a breath, and we're looking for rib movement. We're looking for abdominal wall resistance, and we're looking, can the patient maintain that abdominal wall resistance as they go through an entire breathing cycle. So if the patient has spinal instability, what do we do to treat it? Well, one thing that happens with instability is that some of the muscles become overworked in some of the soft tissues. So this chronic musculoskeletal dysfunction leads to development of trigger points and myofascial irritation in things like the iliolumbar ligament, the lumbar rectors, and the quadratus lumborum. So we're going to perform soft tissue manipulation of those tissues. Sometimes instrument-assisted soft tissue manipulation may be beneficial over the iliolumbar ligament, the lumbar rectors, and the quadratus lumborum. But one of the biggest questions that we face is, do we mobilize or stabilize? Well, as chiropractors, we know that spinal manipulation works, and spinal manipulation has demonstrated tremendous utility in the treatment of many causes of low back pain. But if spinal instability is the cause of the patient's low back pain, then we need to focus our treatment on increasing stability rather than mobility. And there's a study that shows who's going to benefit most from stability. And the study showed that patients who are under 40 years old, they have the active straight leg raise greater than 90 degrees with a positive prone instability test and the presence of aberrant motion when they're performing lumbar flexion, are most likely to respond to lumbar stability exercises as opposed to increasing mobilization. So once we have determined that there's a problem and that we've addressed the soft tissue components, we really need to focus on the ultimate goal, which is to retrain the CNS through repetitive exercise. And by doing that, we can reduce the risk of injury and improve the patient's performance. So what's best to do that? Well, recently McGill and Lee had a paper in the Journal of Strength and Conditioning Research, that was June of 2015, that compared various types of exercise. And what they found was that isometric training was superior to dynamic training to enhance core stiffness. So some of the exercises that are appropriate for that would include the dead bug, the side bridge, and the bird dog exercises. And these exercises obviously target a balanced coactivation of this abdominal canister. So we want the diaphragm, the pelvic floor, the abdominal muscles, and lumbar rectors to work in concert. And the optimal mix of that strengthening needs to be a balance between the superficial spinal muscles and the larger spinal muscles, and obviously the remainder of the canister. So a good exercise for that is a side bridge, a dead bug exercise, a bird dog exercise, and if the patient, especially a female, has issues with pelvic floor stability, then Kegel exercises would be beneficial, and this is simply having the patient lie on their back and tighten their pelvic floor muscles for a count of 5 to 10 seconds. We want to make sure that the patient is breathing properly, so this is going to be performed in a supine hook-lying position. Again, have the patient place one hand on their abdomen, the other one over the sternum, and we're going to watch to make sure that only the hand over the abdomen is moving. So we're going to tell the patient how important it is to breathe from the abdomen. We're going to demonstrate how that's performed. We're going to allow the patient to visualize their deficit of how their hand moves, and then we're going to train that patient to move with only abdominal expansion. And then we're going to have the patient perform that in various positions. We may have the patient move their hands out to their rib cage and pressurize their abdomen. That means pushing out on their hands so that they're initiating breathing through the abdomen. And then we're going to make sure that they feel how their abdomen can remain pressurized throughout the breathing cycle. We'll challenge this in different positions, like having them raise their knees or then move into a sitting or standing position, and finally performing this same breathing, trying to pressurize the abdomen while they move through various positions, like maybe a double squat. So to implement this in your practice with ChiroUp, it's simple. You'll go to the condition menu. You're going to circle the modifier of spinal instability in addition to whatever structural problem the patient may have in their hip or in their lumbar spine. And by doing so, you're going to incorporate the most appropriate exercises and ADLs to make the patient an active participant in their recovery and improve your outcomes. If you wish to review any of the assessments or treatments or exercises that we covered today, or to learn more about spinal instability, simply log into ChiroUp, select Sharpen My Clinical Skills, go to the Condition Reference drop-down, and choose the modifier Spinal Instability. I hope you've enjoyed this presentation, and thanks for using ChiroUp.